Alright, so schizophrenia, what is it? It's a psychotic disorder that affects 1% of the population, and it usually starts between the ages of adolescence and before age 45. The World Health Organization ranks it within the top 10 chronic, debilitating or disabling illnesses, and schizophrenic patients are 13 times more likely to commit suicide. The disorder is characterized by positive symptoms, so things like hallucinations and delusions. There are also negative symptoms like anhedonia, social withdrawal, and apathy. Cognitive symptoms, I'll go through them on the next slide so we can look at them again, but things like memory impairments. The mood aspect of this disorder includes anxiety, depression, paranoia, and suicidal ideation. So here I've just got on the screen the symptoms like I mentioned. So in terms of cognitive symptoms, they may have trouble actually speaking, and this goes hand in hand with their thought disorders. So what about morphological changes? Are there any structural abnormalities? Well, this image on the right is showing an MRI scan of twins. The one on the right has schizophrenia, and you can see that the brain ventricles are enlarged, as well as overall they seem to have a decrease in grey and white matter. So what is underpinning this pathology? It's actually thought to have a couple hypotheses trying to explain it. So the first is the dopamine hypothesis, and this arose from the observation that positive symptoms can actually be seen, as they are in schizophrenia, with individuals that use amphetamines. So amphetamine and cocaine are stimulants that work to enhance dopaminergic neurotransmission, specifically increasing its release at the mesolimbic pathway, which is going to result in the feelings of a high, so that pleasurable euphoria, but also mediates the issue of addiction. So the mesolimbic pathway consists of dopaminergic projections from the ventral tegmental area to the nucleus accumbens, and like I said, this pathway is responsible for feelings of reward, motivation, and pleasure. Now, the dopamine hypothesis of schizophrenia actually tries to explain the hyperactivity in the mesolimbic pathway. And it says that this hyperactivity in the mesolimbic pathway is responsible for the positive symptoms. So the excessive activation of the mesolimbic pathway is seen with stimulant use, and it's also seen in patients with schizophrenia. Really, what we can see in this image here, I've just put on the top the neurotransmission that dictates the control of this mesolimbic pathway. So on the left we have a normal mesolimbic pathway. So we start at the ventral hippocampus with glutamatergic projections activating GABAergic interneurons, which then inhibits or regulates glutamatergic projections to the nucleus accumbens. This then reduces the activation of the GABAergic interneuron at the striatum, which projects onto globus pallidus GABAergic neurons, which then project to the ventral tegmental area, and this allows for control of dopaminergic projections from the ventral tegmental area to the nucleus accumbens, and this is obviously regulating the dopamine transmission within the mesolimbic pathway. On the right, however, we have the hyperactive mesolimbic pathway. So this is something that I'll talk about once we go through the glutamate hypothesis, but essentially we end up with excessive dopaminergic neurotransmission from the VTA to the nucleus accumbens. There have been plenty of studies that have looked at patients who have been admitted to psychiatric hospitals who were there as a result of a drug-induced psychosis, and oftentimes these patients that have taken stimulant, these patients actually exhibit the positive symptoms. Their brief psychiatric rating score scale is almost indistinguishable from that of a schizophrenic. However, they can be distinguished based on the fact that patients who have taken stimulants have an incessant need for socialization and communication, whereas this is not seen in schizophrenics. Their negative symptoms mediate social withdrawal and avoidant behaviors, which are not seen in stimulant use. So what about the negative symptoms? Here is an image showing us the dopaminergic projections from the ventral tegmental area to the dorsolateral prefrontal cortex, and down here we actually have the ventromedial, which is responsible for the affective symptoms. So this is thought to be a hypofunctioning of the mesocortical dopaminergic system. So essentially there's not enough neurotransmission to these regions within the prefrontal cortex, and that's giving us our cognitive symptoms and our affective symptoms. So what's from this then? You might just want to increase the amount of dopamine in the mesocortical pathway to get rid of the negative symptoms. But the problem with that is if you increase dopamine, how can you do it in a selective manner? That being, how can we only increase dopamine in the mesocortical pathway and not other dopamine pathways? For example, if we increase dopamine globally, then we're going to increase the amount of dopamine in the mesolimbic pathway, which is already hyperactive. So that might just compound and worsen the positive symptoms experienced by a schizophrenic. So there are some queries about the hyperactive mesolimbic dopaminergic pathway. pathway, namely because schizophrenics will actually experience anhedonia as part of their negative symptom. However, the mesolimbic pathway is responsible for motivation and pleasure seeking and feelings of pleasure. So if there is truly only hyperactivity of the mesolimbic pathway, then you wouldn't expect these patients to have anhedonia. So perhaps there is a degree of hypofunctioning within the mesolimbic pathway, but that's not really something that's spoken about a lot. That's just more food for thought. So what is the evidence then for the dopamine hypothesis? Well, there have been a number of papers that have looked at this. I've just put on a few here that I've read. So we have the existence of D2 dimers. This one paper by Wang et al. We were able to observe a 278% increase in D2 dimers within schizophrenic patients compared to other psychiatric conditions, depression and bipolar, and of course comparing with a control. This would implicate D2 receptor dimers within the pathophysiology of schizophrenia. Also, if you look around, then you'll see that often D2 receptors are upregulated, but that's thought to be more of a compensatory mechanism as a result of chronic D2 antagonism from antipsychotics. Other papers have been able to show that tyrosine hydroxylase expression is increased in schizophrenic brains. This enzyme is actually the rate-limiting step in dopamine synthesis. This would indicate that these patients have an increased capacity for dopamine production. Looking at cerebrospinal fluid and performing postmortems on the schizophrenic brains, you can also observe increases in dopamine. Another paper has been able to show D1 receptor downregulation in the dorsolateral prefrontal cortex. So we have D1 receptor downregulation at the prefrontal cortex, which kind of provides evidence for the fact that there is hypofunctioning in the prefrontal cortex, giving us our cognitive and negative symptoms. So what about the glutamate hypothesis? This is thought to underpin all of the dopamine hypothesis anyways. So the glutamate hypothesis is also known as the NMDA hypofunction hypothesis, which is thought to be the result of inappropriate NMDA synapse formation during the development of GABAergic interneurons. And this is likely resulting in the hyperactive mesolimbic pathway and hypoactive mesocortical pathway underpinning the characteristic symptoms of schizophrenia. So in this diagram here, you can basically see the hyperactive mesolimbic pathway. So if I explain that, we start at the ventral hippocampus. Here we have the glutamatergic pyramidal neurons, and since they have faulty synapses, there is NMDA receptor hypofunctioning. So we do not activate the GABAergic interneurons, therefore this glutamatergic projection to the nucleus accumbens is active and it's not being regulated at all. So this will stimulate the GABAergic interneurons within the striatum to the globus pallidus and prevent GABAergic inhibitory actions to the ventral tegmental area. So the dopaminergic projections from the VTA to the nucleus accumbens are not regulated, hence are hyperactive. That's how the NMDA hypofunctioning hypothesis could actually underpin the excess of dopaminergic signaling found in the mesolimbic pathway, resulting in our positive symptoms. So this hypothesis actually arose from the fact that NMDA receptor antagonists like PCP and ketamine are able to induce similar effects seen in the cognitive and negative symptoms of schizophrenia. However, they don't cause the same positive effects. These are actually known as dissociative drugs, but they can cause the same effects seen in negative and cognitive symptoms of schizophrenia. So here is a diagram trying to explain the hypoactive mesocortical pathway based on the NMDA hyperfunctioning hypothesis. Essentially, we just have hypofunctioning of dopaminergic projections in the ventromedial and dorsolateral prefrontal cortex. All right, and what about the evidence for the glutamate hypothesis then, or the NMDA receptor hypothesis? Looking at pyramidal neurons, looking at these glutamatergic pyramidal neurons, there is a reduction in their spine density. There is also observations of dendritic atrophy. There are fewer dopaminergic projections to the prefrontal cortex compared to controls. There is a reduction in the pyramidal somal volume as well. Also, there are reductions in the expression of synaptophysin, which is used to mark synapses. So either there is a decreased expression of this protein or there are actually fewer glutamatergic synapses. There's also a reduction in the excitatory amino acid transporter mRNA in the dorsolateral prefrontal cortex, which would insinuate there is a lack of glutamate reuptake. Schizophrenics also have an increased concentration of kina, which is our kynurenic acid. It's an endogenous NMDA receptor antagonist. Again, goes hand in hand with this hypofunctioning of the NMDA receptors. There are lots of genetic findings within schizophrenia, but I've just put down 2 here. There are lots of studies that find conflicting results between gene expression of particular NMDA receptor or AMPA receptor subunits. However, there seems to be a very strong association between GRIN2A, which is making up one of the NMDA receptor subunits, and this gene SRR, which is required for NMDA receptor activation. Additionally, novel agents that are implicated in glutamatergic signaling, for example, lamotrigine, which is used as an anti-epileptic, specifically by targeting pyramidal neurons that are able to produce glutamate and inhibiting their release by acting as sodium channel blockers. That seems to actually inhibit ketamine-induced psychosis in healthy volunteers. Minocycline is an antibiotic that is able to inhibit the behavioral effects of NMDA receptor antagonists, and this is thought to be a result of inhibition of reactive oxygen species production. And then we also have agents that have actually been released on the market, like sarcosine and bitopertin, which are glycine transporter reuptake inhibitors, and on the diagram on the right, you can see that glycine is actually required to activate our NMDA receptors. So what about a serotonin hypothesis? This is something that's way less spoken about, but it can't be completely ignored. The serotonin hypothesis explains things that the dopamine and NMDA receptor hyperfunctioning hypothesis cannot, such as how stress activates the dorsal raphe nucleus, resulting in the excessive serotonergic drive, or how peripheral features of schizophrenia, including decreased phospholipid content of red blood cells and a poor inflammatory response to the niacin skin test, occur. Furthermore, the use of 5-HT2A receptor antagonist seems to slow the progression of the condition. So a bit more about the 5-HT2A receptors. These are the main cortical serotonergic receptors, and they're actually linked to phospholipase A2. So this would actually explain why there is an altered phospholipid metabolism seen in schizophrenic patients. And it would also explain the poor response to the niacin skin test. Also thinking about 5-HT2 receptor agonists, which are classical hallucinogens, for example, psilocybin, like I say, as a 5-HT2A agonist. And there is a lot of work being done right now with respect to that particular receptor subtype and its role in the corticostriatopallido-thalamic circuitry, which is responsible for thalamic filtering, which is something that schizophrenic patients seem to have a problem with. They're unable to filter extraneous stimuli, and this dysregulation of the thalamic filtering seems to result in that sensory overload that is essentially the hallucinations, whether that be auditory, somatic or autonomic. So how do we treat it? All conventional antipsychotics were based on D2 antagonism, and these are still widely used, and they only treat, however, the positive symptoms. They have no effect on the negative or cognitive mood symptoms, because they are acting predominantly at D2 receptors, so they work to reduce the hyperactive mesolimbic dopaminergic neurotransmission. So they aim to reduce the hallucinations. So examples of these are things like haloperidol, flupentixol, sulpiride, and chlorpromazine. So D2 receptor antagonism in the mesolimbic pathway should occupy roughly about 65% of the receptors. Below 50% and no benefit seen, but over 75%, and that's usually when extrapyramidal side effects are seen. So the most serious side effect observed with conventional antipsychotics is tardive dyskinesia, and that is characterized by the repetitive chorioathetoid or facial movements and repetitive tongue protrusions. And this will actually occur when there is a high proportion of D2 receptors within the nigrostriatal pathway being occupied. And whilst this doesn't develop overnight, it can develop within a matter of months or perhaps years, and it may or may not go away on drug discontinuation, that being it may actually remain a lifelong condition. So one way to try and target this, to try and reduce the symptoms of tardive dyskinesia, would be to use an anticholinergic agent like benztropine, since dopamine and acetylcholine have a reciprocal inhibition. And when we're using antipsychotics, obviously there's an imbalance now between the dopamine and the acetylcholine, so it's able to be available in excess and results in the extrapyramidal side effects. Furthermore, we get galactorrhea, so this is the production of breast milk, and this is a result of antagonism within the tuberoinfundibular pathway. So usually dopamine inhibits prolactin, but because we're inhibiting dopamine, there is nothing inhibiting the release from the anterior pituitary of prolactin, and hence the side effect of galactorrhea can be seen. It also works on off-target receptors like muscarinic receptors, which results in our anticholinergic side effects. So that's our blurred vision, dry mouth, urinary retention, constipation, reflex tachycardia. It also has H1 antagonism, so it results in sedation, and alpha-1 antagonism, resulting in our postural hypotension and tachycardia. And finally, what about our atypical antipsychotics? So these are second generation antipsychotics. Examples include aripiprazole, clozapine, olanzapine, risperidone, and quetiapine, and they act in a very different way. Their main target is not the D2 receptors, because they are actually aiming to target both the positive and the negative symptoms of schizophrenia. So they should have an overall better impact on the person's life, and their main target is the 5-HT2A receptors. And some are actually, for example, aripiprazole is a partial D2 receptor agonist, so it aims to actually increase the amount of dopamine within the mesocortical pathway to try and reduce those negative symptoms. Some quite serious side effects can occur with the atypical antipsychotics. So outside of the weight gain, there is an increased risk of developing diabetes, in addition to some quite serious things like agranulocytosis. So there's a serious reduction in white blood cell count, leaving the patient susceptible to opportunistic infections, as well as clozapine has the ability to reduce seizure thresholds. And there is a lot of interesting research going on in the field at the moment regarding estrogen, since estrogen is actually neuroprotective, and women seem to be protected to a higher degree than men against the brain structural abnormalities. So women actually have a decrease in brain volume, and their enlargement of the ventricles are not to the same extent seen in men. Women tend to have two peaks. The first is seen during puberty, when there is the initial changes in estrogen, and the second peak occurs after menopause, when estrogen drops. One study was able to actually look at around 276 women admitted to psychiatric hospitals, and almost 50% were found to be in the early follicular phase of the menstrual cycle, which is when estrogen levels actually drop. Oftentimes, schizophrenic women are seen to be hypoestrogenic as well. And there have been clinical trials that have given men and women synthetic forms of estrogen. So clinical trials giving 17-ethinyl estradiol to both men and women adjunct to whatever antipsychotic treatment they were on, found to have a much greater reduction in their general psychopathology scores, as well as the fact that estradiol actually increases synaptic plasticity, which is helpful for the cognitive symptoms, where memory challenged men have been given synthetic estrogen, and it has actually showed to maintain their cognitive functions. So there's a lot of potential in estrogen. The problem is that with the doses that they're given in clinical trials, it's far too high. The risk of thromboembolism is too high for it to be given as the general dose. So there's a lot of work in that direction, and it should be interesting to see what comes from that.